Welcome to this short presentation of highlights of the third webinar of a series of 4 concerned with clinical applications of teratology and dysmorphology. This panel of 3 images serves to illustrate the main concepts conveyed in the full version of this webinar. Here we see edema that resolves quickly after birth. This child has a specific diagnosis which at this point is irrelevant. Here is an image of another infant after the edema was resolved, leaving a sequelae, a redundant skin. All of them had edema before birth, detected by ultrasound as cystic hygroma of the neck. The question is, where is the chicken, where is the egg? This sequence of images illustrates dysmorphisms. We see a short nose, we see a rather prominent upper lip with a groove, that means a philtrum. We see relative sparseness of scalp hair, but most importantly, this face talks to us. It tries to tell us, look at me, I'm an instance of, and the question is, of what? The sequelae are then markers of previous events during prenatal life. What does the generality of evidence for fetal embryonal edema suggest? It suggests that it may cause distortions of development of a variety of structures. It also suggests that you should consider the nature of the accumulated fluid, the nature of the vessel in which the fluid is accumulated, that is the vascular lymphatic system, and it suggests you should consider as well as deeper, and that is what tissues are more prone to contain that fluid, to swell up, like the periocular region, for instance. Anytime we have signs and we attempt to metamorphose them into signals, we're talking about an attempt to understand how the cause, which can be variable, can be manifested into signals, which is the pathway schematically shown here. How has this become reality, distorted reality? And here, in this schema, is represented one possible mechanism of expression, perhaps due to etiology X or even Y or Z, because different etiologies can share this impact the same pathogenesis. And it's pretty sure that the edema is associated with Pterygium coli. It's also pretty sure that it's a strong signs that signals the potential that the baby will die and never be born. These are these arrows. Also, we know that in one particular etiology or cause, there is an association with ovarian fibrosis, aortic anomalies, intestinal anomalies, renal anomalies. But there are other patients that have these sorts of associations, so that the buildup of a graph like that is illustrative of the thinking of a physician entering the sphere of synthesis, that is, trying to determine the optimal pathogenesis and diagnosis to link the cause, etiology, with the signs that are truly signals. So we can start with the highlights of the third Teratogenesis webinar. It is important that you remember the previous 2, so you may wish to review them for a fuller understanding of what follows. And that will be important for the next and 4th webinar focused on dysmorphology. These are my professional qualifications, and this brings me to tell you that many of the following screens will be shown very briefly, and you may be unable to read them fully. To do so, stop the motion. And if you want to hear concurrent verbal explanations, which are most important, you should see the full version of this webinar. It was Sir Conan Doyle who called the attention to other physicians like himself of the importance of collecting signs in an unbiased fashion. He created the immortal character Sherlock Holmes. Sherlock Holmes did not collect signs to prove somebody guilty or innocent. He collected signs that were objective, one way or another, and so should the clinician. Any clinician that has a diagnosis in mind is already biased, and his collection of signs is suspect. To fully grasp the ideas and concepts represented schematically here, it's necessary that you view the full version of this webinar. It suffices for me to say here that it is important to remember that teratogens are not equivalent to mutagens. Teratology is not equivalent to medical genetics. Teratogens include teratologic type of phenomena, teratogens that are not impacting the genome, for instance, alcohol, and also include factors like ionizing radiation that can cause anomalies of development directly by impacting the embryo or indirectly by impacting the genomic instructions of the embryo. And furthermore, there's a third category of teratogens which are mechanical or external forces. All of this underscores that teratology is much broader and includes medical genetics, reproductive toxicology, and aspects of pharmacology. This is a fairly important scheme. It underscores that from early stages after fertilization toward birth, the elimination of defective embryo fetuses is maximal, is the highest in the early stages and gradually decreases up to the birth. And once a child is born to 1 year of age, it becomes infant mortality. One perspective is to consider those who are not eliminated as failed teratothanasia. In other words, if all of those with malformations were not born, then all the newborns would have no malformations. That is the idea of natural selection by teratothanasia. After birth, we call this mortality until 1 year of age infant mortality. And here again one has to underscore that the first cause, the most frequent cause of infant mortality are malformations just like they are before birth. And because they are more frequent than 5%, and statistically we say that the norm is something that is as frequent or more frequent than 5%, we are left with the impression that death before birth is normal or is part of normality. To what extent that fits with the concept of medicine and life is debatable. Now, short of total elimination of an organism because of malformations like Teratology, there is what one could call physiologic programmed cell death in particular tissues at particular times. For instance, the cells between the fingers are supposed to cease to exist, thus the fingers become liberated one from another rather than remain syndactylous. That syndactyly could be considered a failure of apoptosis. Well, how about the ducks? Are they a failure? Shown here are two instances of symphodia or serinomelia. And in both instances, there are anomalies of the forearm and a single leg, either that failed to separate or became joint. The point here is that these are twins. The co-twins are not shown, and they could be called two observations in identical twins, but the problem is that they are not identical twins. They are monozygotic twins, and this is an important distinction and an example how language can misinform. And because we have two such instances of rare anomalies being concurrent in one and another set of twins, then the question is, to what extent is this syndromic? To what extent this is a signal of a particular pathogenesis, of a particular embryonic mechanism? And to continue now, we show both members of the twin pair. They are monozygotic, but they are not identical. It's obvious. Just look at the lips. And also concurrent anomalies in twin B, which are not observed in twin A. In fact, monozygotic twins, where there are congenital malformations, rarely both have the same. And therefore, if the genes and the genome are entirely identical, then what is the cause? Well, the cause may be the environment, maybe the circulatory characteristics of the placenta feeding both twins. Since they are monozygotic, probably the placenta has intercommunications. And these are examples why pathogenesis is an indispensable co-factor in the understanding of the etiology or causes of malformations. Here are shown 5 images related to the edema that we had discussed previously. We have an early edema in the fetus, which is frequently fatal. Then you have Down syndrome, which frequently is associated with edema, and the edema leaves a sequelae, a consequence of a bull neck or a prominent pterygium redundant tissues. Here you have a baby with Down syndrome born with edema that resolves pretty much in few days. These are examples that require careful interpretation. An edema can distort structures not only of the neck but even of the fingerprints. And these are carvings of the skin, dermatoglyphics. And once they are set, they remain immutable for the rest of the life of the individual. So growth will not change them, like the shape of the ear or the nose. These will be here forever. And therefore they can be diagnostic, very useful to establish a pattern that is characteristic of specific syndromes. So here is an attempt to show a dendrogram of how the edema may distort development, for instance, relationship with the pterygium coli or the abnormal carrying angle and so forth. This is an example of an attempt to interpret the mechanism, the process of transformation, the etiology, into a sign through a sequence we call pathogenesis. And in the case of alcohol, we know that it's not a mutagen, therefore the effects of alcohol are direct on the developing embryo through the epigenetic mechanisms, which include the production of microcephaly. Well, if this was a mutagen, there was a second additional mechanism where the teratogens could mutate the genes, and then the genes would then be incapable of creating a normal morphogenesis. Here is an example of a teratogen that is a mutagen and is capable of direct effects and is capable of effects postnatally and is capable of affecting subsequent generations. And one of the repertoires of ionizing radiation is microcephaly. So this is the reason why when we study the effects of Chernobyl, which microcephaly is one of them, we cannot stop but also include studies of alcohol. So here is another graph showing additional expanded interpretations of how a single etiology, we call A, could have a diversity of impacts on pathogenesis, which will explain the variability of manifestations, like for instance alcohol will manifest in a diversity of ways, so will radiation. If this etiology impacts early and impacts only one pathway, you may end up having one anomaly. If this etiology impacts one pathway, but it impacts the same pathway again and again and again because the radiation is persistent or the consumption of alcohol is persistent, you may have then multiple anomalies that are a cascade of impacts on the same process. The same etiology may impact more than one way of expression. In one, there may be 3 hits or 2 hits, and you're going to have a whole syndrome of potential manifestations, very difficult to analyze. Of course, the comments in the full version are more detailed, but that should give you a rough idea of what we're talking about. And so we have reached the end of the highlights of webinar on teratogenesis. As already stated before, the next is a supplement that contains visual elements that are included in texts that are required to obtain certificates of participation. You should see the supplement, but if not, I take this opportunity to thank you for your attention, and I hope to see you very soon again. Welcome to Basics of Dysmorphology, Part 8. This part is focused on hypotonia. After infancy, this sign is harder to detect. And what is hypotonia? Hypotonia implies a decrement or decreased tone or tension of tissues, in particular the neuromuscular and muscular systems.